Any question for Professor Kwan? I think everybody happy. Thank you, Dr. Kwan. Thank you so much. While we wait for our Honorable Health Minister, I would like to quickly go through the new Regulation Act, which I feel we should all know about it, because there are some very, very important points we should know. The regulation, as I said, passed just last week, on the Monday morning, and then we did the transplant. We did the liver transplant Wednesday morning. That's how it went. So the council, the transplant committee, and everybody were under so much of pressure that we had to do it quickly rather than going through it one by one. I'm sorry for that, but done for the country, done not for any single individual, done for the country and poor people of Nepal. So I just want to go through what is about our brain death regulations and what about our regulations for the deceased donor transplantation. In our estimate, we do about 3,000 kidney failures every year and liver failures about 1,000. We don't have any idea about heart or lung failures. And transplantation facility, we do only live renal transplants, live donor renal transplants, about 150 a year, which is far less than the demand. 3,000 demand per year, but transplants just being done about 150. So the demand and supply is so disproportionate. So I think for this big discrepancy, the solution can be the deceased donor transplantation. Dr. Kwan mentioned that deceased donor transplant, they were not very good to start with, 7 transplants a year at the beginning, but that was liver. I don't know, even kidney, will it go like this in Nepal? But I feel that we have a very huge potential source for the deceased donors. So I think we should do better in kidney transplants from the deceased donation. Liver, Dr. Kwan just started, so I think it's a long way to go, but we don't know about heart or lung transplant, though we have got 2 well-trained heart and lung transplants in the center, Dr. Mon and Dr. Sampurna. The data shows that 5 deaths every day by road traffic accidents. And in Kathmandu alone, 1,000 brain deaths every year. This is a snippet, but that is more or less true. And from one brain death, we know 8 major organs, 2 kidneys, 2 lungs, 1 liver, 1 heart, 1 pancreas, 1 is the small intestine. And so the corneas and skins and all. And no definite risks for the donor in brain death is already there. So this is a huge potential in terms of quantity, in terms of quality. There's no risks of any damage, easily available resource, but all being wasted at the moment. And as Dr. Kwan said, as he mentioned about the deceased donor program in India, they're really not doing well at the moment compared to the living donor liver transplant or kidney transplant. I think in our country, we might make it different. We might be lucky to use all our organs, or majority of our organs, even 20% of our organs. If we use it from 1,000 brain death, we can use brain death of 200 persons. That means 400 kidneys. That is much more, number than what we are doing now, and that is a huge potential. Even if we use only 20% of the resources. But there are things to be done in deceased donor program, like identification of the potential donors. Not all brain deaths can be the truly donors. And the early confirmation of brain death should not be in a lapse of time. And consent is very important. The new regulation has clearly mentioned that the family consent is good enough for the organ donation from the brain dead person. So if the person has not given the consent before he or she dies, we don't have to wait for his consent. The family consent is good enough. And the most important thing is prompt notification of the retrieval team. Dr. Khan mentioned there is a compulsory system of registration of the brain death declaration in Korea. And we also have the same system in this new act. Every brain death in any center must be reported to a coordination unit. Coordination unit has been dedicated to human organ transplant center at the moment by the Act, because it should be functioning round the clock, immediately without delay. So the government has realized that that center can be, the potential, functioning unit for the this sort of, mechanism, information, and then managing the retrieval of the organs and distributing the organs according to the criteria without any sort of personal interest or coercion. So that has all been done at the moment. So notification must be done, must be registered, must be reported to the coordination in the transplant center, and then the coordinators will be acting on it, will visit the donor center, brain death center. They thoroughly go through the documents to see the mood and motive of the donor family and medical fitness of the donation. If that happens, then the donor team and recipient team, the retrieval team and the transplanting team will be informed, will be made ready, and then the action will be done. So rapid retrieval of organs and then action. So once the organ were together to formulate the act and the regulation, so that is according to international standard, no problem. So once this brain death is declared, so as I said, the retrieval team is informed, the donor coordinators are informed, and they act the way possible in the quickest time possible. And in different countries, different level of criteria for the donation. We have actually not mentioned about the age limit for the donation, but normally about 65 years age at maximum should be the good donor. Other criteria is necessary for the donation to be in good creatinine levels, no history of kidney diseases, and test this biology test negative, no sepsis, no malignancy. These are criteria to be a donor. And the challenging part is this is very brain death patients are very unstable ones. So definitely the stabilization from the intensivist or anesthetist, we were taking care of the patient and manage the donor, optimize the all organ functions so that the organs are at the best. And once the organs are retrieved, preserve them. The incision is usually made from suprastral nose to the symphysis pubis, long incision. Retract the thoracic external retractors and the abdominal retract the whole abdomen and chest. The organs retrieved, from whatever way the cardiac team is retrieving the heart and lungs, the liver teams, SPV teams, liver, kidney, pancreas, and so many organs are retrieved like this. And preservation is very important. There are different ways of preserving, and with what the preservation fluid to keep the organ optimum is the, I think, key factor to keep the organ safe. So there are some things like hypothermia must be maintained around 4 degrees, prevention of edema, prevention of acidosis, and neutralize the formation of reactive oxygen species. And these are maintained by, some preservation fluids, in preservation fluids like, different kinds of universal Wisconsin solution or STK solution are used containing all these, ingredients to keep the organ safe. STK is available in Nepal now, and we are ready to act on the deceased donor kidney transplant at the beginning. And if from human research point, if we are okay, we are capable, then we also go for the liver retrieval and liver transplantation. But definitely we are ready to start the kidney at the moment with all kinds of physical infrastructure and human resources. 2 teams are ready now, one for the donation anytime, and one for the implantation anytime in the center. So I definitely like to get the calls from any center, wherever you work. Please let us know. We are ready to save kidney failure patients now, anytime, anywhere. So once the organs are retrieved, packed like this in the plastic bag and kept in the ice box. And the recommendations normally, national protocol development, Dr. Kwan clearly mentions one center, one man cannot do it. Needs much more many more human resources and infrastructures, and all the hospitals must be coordinated to make it success. Maintenance of the common list for the recipient. The Organ Transplant Center has been given this responsibility to maintain the national database of the recipients. The human organ transplant center must be informed about the donor availability, I had mentioned. And that's how it works. The coordinators will definitely be there once the message is received. We need to educate the public. Dr. Kwan clearly mentioned public education is so important, otherwise they will never donate, this will never happen. And legal pathways from the government point, we have got all the legal clearance, we have the good guidelines and regulations to go for the deceased donor transplantation. But from the human resources, how many surgeons are ready to the retrievals, to the implantation overnight, weekends and all the time, that is the question. Couple of surgeons is not enough, cannot do overnight, day and night works. So it needs more and more surgeons, anesthetists, and of course physicians to work for the success of this donor program. And transplantation and post-op facilities, almost the same as for the live donor, but definitely it's more than for the deceased donor program. And operating theaters and ICUs must be standard, because the donor hospital must have a very safe, standard operation theaters. Otherwise, the donor contamination means the effect will be on the recipient side, and immunocompromised recipient, the outcome will be not good. So the procedure of organ transplant, when the declared coordination unit at the transplant center must be informed, and transplant coordinator assess and coordinate, donor and recipient team inform and prepare, transplant committee inform, so that if the committee, there is a special committee provision with the representative from that donor center, administration, representative, the post-mortem medical expert, the forensic expert from the medical doctor, and police official representative. 3 of them forms a committee who gives the permission for the organs to be retrieved before actually the forensic test. It is must in our regulation. Otherwise, if the permission is not given, organs cannot be retrieved, and after the postmortem, the organs are just not fit. They are contaminated and will be useless. So there must be permission from the special committee of Dr. Osti's team. From police officer, my colleague is here, DIG from Nepal Police, who is here to support us, Mr. Ram Kumar Kanal. Yes, and administrative officer representing that organization. 3 specialist members of the team will decide whether the organs can be retrieved before the postmortem or not. Once that clearance is granted, organs can be retrieved and distributed for the transplantation. I quickly go through females and males. And after the first set of scoring, whoever gets the first highest score will be called for the organ. They are offered for called for the organ for the final evaluation. Final evaluation done by the PRA testing, DSA testing, and CDC cross-match. From this, whoever got the top score will get the organs. That's for the kidney. For the liver, Dr. Dipis has made the special criteria for the liver with the super urgent list also for the poisoning like paracetamol poisoning, mushroom poisoning, or acute graft failure after the liver transplant. These are the super urgent list. These people will get the liver wherever it is available despite other score system. Otherwise, pretty standard liver transplant criteria for the deceased donation. You want to say something about this? No? Okay.